In this video, we will be going over chronic obstructive pulmonary disease, also known as COPD. I will read the question, then pause so that you can see what you remember. Then I will read the 4 options, and then we will have a short discussion. This is just a quick overview of COPD. If you need more information, you can find that in your respiratory chapters. These questions will also go into medications, steroids, methylxanthines, bronchodilators, which are your beta-adrenergic agonists and your anticholinergics, as well as the phosphodiesterase 4 inhibitors. That is hard to say. Okay, here we go. Question number 1. A nurse is precepting a new graduate. Their assignment has a patient with a chronic obstructive pulmonary disease, COPD, and another patient with asthma. The new nurse is correct in stating the difference between the two when saying, is it number 1, asthma is reversible, COPD is not. COPD, such as emphysema or chronic bronchitis, is reversible, asthma is not. 3, the alveoli in asthmatics are permanently damaged. Or number 4, asthmatics will live as CO2 retainers. The answer here is number 1. COPD is chronic permanent damage to the alveoli that happens over time, usually from smoking or constant exposure to chemicals and toxins. Asthma, however, is acute bronchial constriction, airway edema, and mucus production from a triggered response. The immune system maybe just does not like it when the patient is exposed to cold air, exercise, smoke, allergen, bad air. And so it's important to know that asthma is acute, so you can remember A for asthma, acute. And you can also remember that COPD starts with a C, C for chronic. So the answer was number 2, and this just reviewed the quick difference between COPD and asthma. Question number 2. A nurse is caring for a client with COPD or emphysema. The client's arterial blood gas or ABG results are the following. The pH is 7.32, the CO2 is 55, and the HCO3 or bicarb is 24. The nurse knows the patient is experiencing Give you a little extra time on that one in case you were trying to analyze that ABG. Is it number 1, respiratory alkalosis, number 2, respiratory acidosis, number 3, metabolic acidosis, or number 4, metabolic alkalosis? So you could have had 2 ways to get to the right answer, which is number 2. You could have remembered that emphysema patients are in a chronic state of respiratory acidosis because they cannot exhale that CO2. And CO2 is acidic, and so therefore if they're holding on to that, they're going to be acidic themselves. You could have also gotten to the answer by analyzing the ABG. If you look, the CO2 is high, and that's your respiratory buffer, meaning it's a respiratory issue, and your pH is low, meaning it's acidic, respiratory acidosis. So the answer again was number 2. It's a good idea to know how to do at least your simple ABGs, which is what this one is, and to know the ABG changes associated with any disease you study, and in this case it was COPD. I've got a little hint for you guys here before we move on. If you had an issue with your ABG ranges, if you look at the pH, the 7.35 to 7.45, and then look at the CO2, pull down that 35 and 45 from the pH, and that gives you your CO2 range. So just a little hint there. And also, if you're taking the next gen NCLEX, changing here April 2023, you will not have to memorize your ranges anymore because they will include the ranges anytime they give you numbers. Next question. Question number 3. A client is admitted with emphysema exacerbated by the flu. The nurse would expect the patient to present with which of the following clinical manifestations? Select all that apply. Is it number 1, a barrel chest, number 2, a longer inhale time, number 3, a longer exhale time, and or number 4, fatigue? So because this is select all that apply, we're going to do the true-false method. Number 1 is true. People with emphysema, they have a really hard time blowing out that CO2. They end up with that barrel chest. Number 2 is false. It doesn't take them longer to inhale. It takes them longer to exhale, making number 3 true. And it's very tiring to try to get the CO2 out of the body. And so that makes them very fatigued. And so that makes number 4 true. So 1, 3, and 4. The thought here is to remember as much as you can about emphysema. And also, we do have the flu in the mix too, so it wouldn't be wrong to maybe pick things like fever and chills, things that present with the flu. So we're going to take a second here, and if you want to screenshot this, this is all the signs and symptoms of emphysema. Shortness of breath, which is dyspnea, dyspnea on exertion, we also call that DOE, fatigue, malaise, weight loss. Their metabolic rate is very high because they're constantly trying to breathe off that CO2. They end up losing weight. So they typically have the barrel chest with a very skinny arms and legs. Tachycardia, especially with activity intolerance. Tachypnea, that fast respiratory rate. We already talked about the barrel chest. The respiratory acidosis. And because they're in a chronic respiratory acidosis state, they're always retaining that CO2. We do label them, especially in the end-stage CO2 patients, we call them CO2 retainers. The emphysema may or may not present with an oxygen issue. If you're thinking oxygen, you might be thinking about the other type of COPD, which is called chronic bronchitis. These patients are also, if we continue here, red or pink looking. That CO2 can make them be that red or pink color, and they're puffing a lot, trying to get that CO2 off. Lots of mucus starts trying to cover the damaged alveoli. They create a lot of sputum. They're coughing. They may have a pleural rub, crackles, rales, rhonchi. They're overinflated, so if you percuss, you should hear hyperresonance. What we really need to be careful of is that these lungs aren't going to collapse, which is atelectasis, or that they're going into an exacerbation like this patient was. Their lung issue was exacerbated, which means it got worse because they caught the flu. And anytime they catch something respiratory, like an upper respiratory infection, or if they're exposed to smoke or pollution, it just makes them a lot worse. And that's usually when they end up in the hospital with us. So if you needed to, review those COPD signs and symptoms again, and make sure you remember them. Question number 4. A client with COPD is placed on 4 liters nasal cannula for shortness of breath. When the nurse returns to check on the patient is unable to be aroused and is breathing at 8 breaths per minute. What is the priority nursing action? Is it to, number 1, call a code and start rescue breathing, number 2, turn down the oxygen, number 3, notify the doctor, or number 4, sit the head of the bed up? The answer here is number 2. You need to turn down the oxygen. I hope when you read this and saw 4 liters, some red alarms went off. You should have learned in nursing school to not put a COPD on more than 1 to 2 liters. And the problem is, because the patient's oxygen is up too high, it is suppressing their drive to breathe. So therefore, we have to lower the oxygen level. You and I respond to our CO2 levels to breathe more or less. We have to remember this COPD patient is constantly in a state of CO2 retaining, so they can't respond to CO2 levels to breathe anymore. And so the brain will turn to oxygen levels to breathe. And the only reason these guys breathe, especially in end-stage COPD, is if their oxygen levels are low. And the minute they're on 4 liters, their oxygen levels go up, and the brain just doesn't think the patient needs to breathe anymore. So the number 1 thing you have to do to basically save their life is turn down that oxygen, and you will immediately see them start taking more breaths. So that would be your priority action. And we do have objective data, which makes sense that we're ready to intervene here. And in this case, all the answers were interventions anyway. So it's a good idea to understand and make sure you remember that what a CO2 retainer is in chronic COPD, and that they cannot be on a lot of oxygen. In fact, their oxygen saturation should really stay between 88 and 90%. If you put them up higher than that, you might do what's happening to this patient. Question number 5. A nurse is planning care for a patient admitted with COPD exacerbation. Which medications would the nurse expect the provider to order? Select all that apply. Is the answer number 1, prednisone, number 2, theophylline, number 3, albuterol, number 4, roflumilast? Because it's select all, let's go ahead and do the true-false method. And number 1 is true, that's a steroid. Number 2 is true, that's a methylxanthine. Number 3 is true, that's a beta adrenergic agonist. And number 4 is true as well, that is a phosphodiesterase 4 inhibitor. So some other medications that the doctor could possibly order would be antibiotics in case the exacerbation was caused by a bacterial infection, maybe the bronchodilators. The other bronchodilator is the anticholinergic or antimuscarinics like ipratropium. So this is a good review of all the medications possible for that COPD coming in. It's a good idea to know them. I do have another video that goes over them that you can check out more in depth. And while we're here, we're just going to go over the other interventions in that plan of care for that COPD and wrap this up nicely with our last question here. So again, if you want, take a screenshot. I know it's a little small there for our eyes, but there's a lot. We want to make sure the COPD can conserve their energy, so no doing PT like right before they eat. Remember, they have a high metabolic rate. They're breathing heavy and fast. They're getting skinny. So high calories, low carb, high protein. Keep those foods soft so it's doesn't take too much energy to chew them. Drink between the meals so they can get as many calories in as possible while they eat. Cold food so you're not producing a lot of heat and taking up room in that stomach, which is then going to push against the diaphragm and give them less room in their lungs. Brings us into that next one, to keep that lung space. Small frequent meals, no gas producing foods, and if necessary they can do that lung surgery and take out some of the damaged alveoli there, give them more space in the lungs. Decrease the mucus that the COPDers can have, humidify their air, definitely humidify their oxygen. Oxygen is drawing. Watch how much they're around the AC or in the cold air. That can trigger more mucus. The chest PT, cupping your hands and smacking their back, helping them loosen it up, as well as the chest wall vibration. We can give them expectorants like guaifenesin or other mucus agents to help them get rid of that. Help them get the CO2 out. If they start breathing through pursed lips, that can help them elongate their exhale and get that CO2 out. And then, of course, try to get them to stay healthy. Get their vaccinations, because if they do catch the flu or something, that could trigger an exacerbation. Other things that can trigger exacerbations: smoke, pollution, bad air, allergens, and environmental triggers. So that's a lot there. Take a screenshot if you want. Review it again. Lots of interventions for people with COPD. I hope you enjoyed this video reviewing COPD, critically thinking, and learning through questions. If you like this content and you want to do more, subscribe to our channel and find us at sciencestrategies.com, and please don't forget to like this video.